Thank you very much, Nelson. I didn't understand too much, but I think what he said was probably nice. So also thank you for giving such a generous time allotment for this topic, which may be appropriate because it's so important. I would like to start with this picture I like so much. It was taken by a friend of mine from Sweden. His name is Lennart Nielsen, and he has made this fantastic book about the development in utero. And this book also contains this picture at the very end, where the birth is shown from the right perspective, which is the perspective of the new mother. And you see the midwife. And I think this is what the topic is all about, that every woman in the world should have the right to have all the help she can get to deliver healthy for herself and for her baby. But what are the facts? The facts are that about 350,000, at least 350,000 women die around childbirth every year. This used to be even higher, but 350,000 is still totally unacceptable. It means, if we translate it, that every minute of this talk, one woman will die, mainly in Africa, but it happens all around the world. So one woman dies from a pregnancy-related cause every single minute. What is a pregnancy-related cause? It needs to be defined, and it has been defined by WHO. It is the death of a woman while pregnant or within the first 42 days of the end of a pregnancy, irrespective of the duration and the site of the pregnancy, so it could even be from an ectopic or abdominal pregnancy, from any cause related to or aggravated by the pregnancy or its management. But we don't speak about accidents or incidental causes in pregnancy. So what we are talking about is really pregnancy-related, caused by pregnancy. So what does it mean? And I think it becomes even more dramatic if we look at the lifetime risk, the added risk of a woman to die from a pregnancy-related cause. It ranges in this world really over an amazing span from 1 in 7 to 1 maybe in 50,000. So depending on where you live on this globe, you might have a chance, a lifetime chance of dying around childbirth of 1 in 7 if you live, for example, in Niger, in Africa. And let's say you live in Ireland, where we have good numbers, it's dramatically lower. And this is a divide that is really difficult to accept in a world that otherwise is so globalized. So this is an issue of inequity, and I think all obstetricians should be concerned. Well, there was a report recently, and most of you have seen it in the Lancet, but it has, of course, all these different sources that lists the distribution of these 358,000 maternal deaths that we have every year. And you see that 355 of those are in low-income countries, and the vast majority is in Africa, followed by Asia. You see that Latin America and the Caribbean are really a smaller contributor to this death toll. And on the right, you see the lifetime risks expressed as 1 in the number of women who will die. So, it is one of the major health inequities of the world. 98 up to 99% of all these deaths are in low-income countries. And in total, it's more deaths than the deaths caused by HIV or AIDS. And I think there is much more attention in the world being paid to HIV and AIDS, which is important, but maybe we have only lately realized how important the maternal child issue is around childbirth. So even if we stay with HIV/AIDS for a short while, what we see here is that even in this disease that can be transmitted heterosexually, as we all know, still the biggest burden is in women. So this disease also has a women's face. And if we go back to the maternal death and look at the different continents, you see that also the spread among the continents is quite striking. But what does it mean for the newborns if a mother dies? What is the situation with newborn health? Well, it's 4 million newborns dying every year, and an additional 3.2 million babies are stillbirthed each year. And you may have seen The Lancet just this past week or so had a big issue on stillborns, because here the progress has been remarkably slow. And if we then ask, why do newborns die, these 7 or more than 7 million, well, many of those die because the mother has died. This is, of course, a very bad prognosis for a child if she loses the mother at childbirth. And then, of course, there are all these other problems, the inadequate care in the critical hours right after birth, and the mother's poor health in general. So in summary, we can say that the prevention of death of mothers may be the single most important intervention also for the health of children. And well, if we read this Lancet article by Horton, we may think the situation has improved from, let's say, 500,000 deaths to 350,000. But what you can see regarding this divide that I spoke about, that the difference is growing. So if we have in green here the low-income countries, and in blue the high-income countries, and if we look, let's say, this 30-year period, the decline in maternal death rate has been less in the low-income countries than in the high-income countries. So morally, this is even more of a burden now than what it used to be. And what I've presented so far are just numbers. They are just cold statistics. But behind these numbers, of course, there are all these individual losses. And I think what we should do, and everybody here in the room has these personal contacts and experiences, is to ask what is behind these numbers. What happened to these families that sometimes never became a family? And doing so, I'm personally involved at the moment during my Berlin sabbatical, especially with studying Africa. And there is a saying that women use in certain parts of Africa, for example in Tanzania here, when they go to deliver a child, they say, "I'm going to fetch a new baby. The journey is dangerous and I may not return." And again, to put it on an individual base, let's look at this child. This child is born in Sierra Leone in Africa, may not have a name yet, or may never have a name. The weight, the length, all of those parameters were not taken, no APGAR score at birth. And the life expectancy of this child is 39 years. Now we look at a child being born on the same day, let's say somewhere in Europe. It has these measurements, and the life expectancy of this child now is 82 years. So this difference continues. So this means that children born in the poorest countries are 20 times less likely to reach their 5th birthday compared to children in high-income countries. Amazing difference. So 6 million stillbirths or newborn deaths. We already mentioned that, but what that means for these mothers, all this disappointment, I think we can imagine. And all of this, finally, I think, has reached the international bodies. And we were lobbying for that. I was personally, for example, going to Ottawa where the G8 and plus 5 and the G20 meetings were taking place. And we were trying to tell the politicians how important this is. I think they realized, and the prime ministers listened. And then the Secretary General of the United Nations, Ban Ki-moon, stepped in, and he announced at the end of last year that the United Nations will spend quite a bit of money on women and children's health. And so I think now it's our obligation to watch that this really comes true. And we have to keep up the pressure. They didn't know exactly how they wanted to administer it. Recently they have decided to go for model countries, to see countries that are committed, that are achieving something so that others can learn. There are different ways of doing it. We have to watch it. But Ban Ki-moon said, we know how we can save lives of women and children. 16 million women and children can be saved within 2015. Very ambitious, but I think it's great that this is so high on the agenda now. So now we have to provide the data. We have to really make the support work. So the first question we have to ask is, why do mothers really die? What do they die of? Well, there are all these reports. Like in the UK, there is the confidential inquiry for many years now. It started in the 50s as a small booklet. Now it's a big book that has every single maternal death occurring in the UK being analyzed. And from these data, I think we get an impression of what the causes are. So in the 50s, in the UK, it used to be 1 in 1,500. Now it's 1 in 30,000. And I think the reporting, the data recording, the discussing of these individual cases really helped to improve the situation. And this is now the distribution that WHO collects. 25% of those maternal deaths are due to hemorrhage, to postpartum bleeding. Infection is still the second most frequent killer of women. But today we spoke a lot about preeclampsia, eclampsia. It is responsible for 12%, followed by obstructed labor and unsafe abortion. So these are the really important ones that we have to get better with. And what that means is, especially if we think of hemorrhage, we kind of know that the majority of those could be prevented. Also, obstructed labor, we could do a lot with low-cost interventions. And even with eclampsia, we could do much better prevention, and I will show that we don't use enough of it yet. Complication of unsafe abortion, of course, is a tricky issue because their religion comes in and restrictions apply. So obstructed deliveries is, of course, responsible not only for death of babies, but also for severe maternal complications like fistula, and you know that this can lead to very difficult positions of these women. They are often abandoned by their husbands, and so obstructed labor is a big problem. Postpartum hemorrhage, you are very familiar with that. In settings where you have everything available, blood, drugs, surgery, you can deal with it. It has gone down dramatically in high-income countries. But what can you do if you don't have the proper equipment? I think even very skilled obstetricians will have problems to deal with it. And just remember, this Taj Mahal, this fantastic building, more than 300 years ago, it was built by the Sultan Mahal because the woman, his favorite woman, Mumtaz, she had died at the birth of her 14th child from the consequences of postpartum hemorrhage, and he refused to eat afterwards. He was so sad about the loss that he built the Taj Mahal. We know what to do in case of postpartum hemorrhage. We teach our students to consider the 3 Ds that are responsible: the delayed transport, the delayed diagnosis, and the delayed treatment. We know what we can do surgically, for example, this B-Lynch suture. There are varieties of that, and we found them to be quite useful. In our hospital, of course, we can even embolize the uterine artery, which, if the radiologists are next door, is an option. But, as you know, there are these low-cost varieties that should be there, like the tamponade. There should be a person attending the delivery who knows at least how to apply compression. And there is this issue of misoprostol, where we have done some studies on, some randomized studies, really convincing ourselves that it is a pretty safe drug if applied properly. It can prevent protracted labor. You should only give it every 6 hours, 25 milligrams, and so on. You know the safeguards. Don't do it in a scarred uterus. But if it's applied properly, it's a very good drug, and randomized trials have shown that convincingly. There is a concern, and unfortunately the medication is off-label, even in Europe. The company, unfortunately, is not applying for the obstetric use. I think it's too cheap. They don't want to provide the studies in pregnancy. They would be too expensive. And it's a big burden on the shoulders of those who apply the drug if they have to use it off-label. I think we are happy, and FIGO, I think, had a part in pressuring the organizations like WHO to put it on the list of essential drugs, at least, so that we have some safeguard. Misoprostol is listed there. And here you see the meeting that we had in Geneva in 2004 of FIGO. At that time, the president here, Arnaldo Acosta, was from Latin America, great president. Next to him, Dorothy Shaw, the next president. This is Shirey Chet, and so on. You know Luis Cabero-Rura. And I was hosting this as a president of the Swiss Society in Geneva. And then we were saying that FIGO has to come out and say that this should be available because it will save lives. We made a statement together with the organization of midwives. I think we have to work closely together, doctors and midwife. So the statement was that every mother giving birth anywhere in the world should be offered active management of the 3rd stage of labor for the prevention of postpartum hemorrhage. Every skilled attendant will have training in active management of the 3rd stage of labor and in techniques for the prevention of PPH. I think it's important to put this on the agenda so that also our politicians read it. And in this International Journal of Gynecology and Obstetrics, where I'm associate editor, we had a whole issue on this postpartum hemorrhage. And this journal has quite a distribution all over the globe. I spoke about, or I mentioned preeclampsia being the 3rd most frequent killer. Again, we could do more. There are all kinds of guidelines out, but if we, for example, look at the issue of magnesium sulfate, even though it is clear that it is useful, it's not too expensive. It is on the WHO list of essential medicines. But what is the fact? The fact is that only 64 of the 112 nations that were surveyed had magnesium sulfate as part of their guidelines, as part of their policy. So this is only half of the countries. I'm sure that here all the countries have it, but you will be surprised how bad the situation still is around the globe. And there are still, especially in Africa, and we have to pay attention, of course, to the local beliefs and the traditions, but many of the traditional medicines used really don't help. There are some that are quite helpful, but some others will not prevent the disasters. So we know, again, that most causes would be preventable. And now the question comes, what can we learn from examples of countries that have tried to tackle the problem? Well, one recognition that came already some years ago is that there should be a skilled birth attendant at every delivery. And we know that the skilled birth attendant, this is a review of the issue by WHO, really helps, because here you see the correlation between the maternal deaths per 10,000 here on this axis, and here is the percentage of births attended by skilled birth attendants. And it's an amazing correlation. So the less birth attendants you have, the higher the maternal death rate is. So there's no doubt that this is helpful. But, as I said before, sometimes even the most experienced obstetrician would be lost out in the field if you don't have the facilities available. So what we think is that probably skilled birth attendants for the periphery were overemphasized by WHO. And my personal experience in Eritrea, it's a very small country, 4 million people only, was that when we started to increase the attractiveness of the hospital, first in the capital, the number of deliveries was going up from 5 to 10,000, and now in Keren, the second biggest city, then we saw a dramatic decline of the perinatal mortality and of the maternal mortality. So I personally think that birth attendants are important, but we should also try to centralize obstetric services. Well, here you see this correlation, again, delivery attended by skilled attendants. You see there are some regions where in the majority of cases this is not given yet. So we have to get better in both arenas, centralization on the one hand and skilled birth attendants. And there has to be access, there have to be ways in countries to make sure that in cases of emergencies, these centers are accessible. So the barriers to care, the delays, are on many levels. There are the socio-cultural ones. I mentioned the traditional healers in Africa. There is the issue, the practical issue of the transport, and then the general issue of having poor quality care, poor resources, especially in the periphery. But there are other issues that we also have to keep in mind. And if we speak about the cultural aspects, we have to see them because they have major, major impact. Let's take the example of teenage pregnancies. Here you see a picture of a young woman, we can call her a child, who got married, certainly without her consent. And we could ask, what is the impact of this? Well, we know it has a major impact. It increases with each successive pregnancy the risk of maternal mortality, so there should be shorter intervals. Adolescent girls are likely to obtain prenatal care and other related assistance, more likely to suffer from pregnancy-related disorders and complications. So if you are between 15 and 19, you are twice as likely to die from pregnancy and childbirth. And if you are between 10 and 14, and you see those pregnancies, I'm sure here as well as in other parts of the world, it's 5 times more likely that the woman will die from childbirth. And now we can ask, did the situation improve? Well, if we look at Africa, yes, the number of births in the teenage age group went down, but it's a very slow progress. And it has been stagnant in a way. Young women often, have to live in the street and they don't have good care. So I think what Fatala, another president of FIGO, once said is right. He said, women are not dying of diseases we cannot treat. They are dying because societies have not yet made, or often enough, they have not made the decision that these lives are worth saving at all. There is this whole issue of the role of women in societies. And out of all of these facts, initiatives have started, which I think in the end could be quite useful. The first was the Safe Motherhood Project. It started in the 80s. It was supported by many United Nations organizations, had the ambitious goal to reduce maternal mortality. But the facts again, if we look at the United Nations figures, the aim that was defined by the Council was that every country should spend 0.7% of the gross national product for developing aid. And you see here that many countries do less. The average is 0.41% only. And I'm not very happy to say that, for example, Germany is also below, way below this 0.7%. And I think we have to work very hard on our politicians to change this. Africa was told already, if you add all these commitments up, 60 billion in financing in 2010, but actually 20 billion less were paid. And this, has led to the fact that the progress is too slow. And if we go through the different areas of progress, and if we start with the poverty issue, people living on less than $1 a day, there has been some progress in the world in the 90s and in this century, but it's not good enough. And if we look at the issue of schooling, another United Nations aim, you see the progress has even been slower. And if you calculate it, and 2015 is kind of the aim that has been defined, then the estimate would be that more than 100 million school-aged children by the year 2015 will not have proper school education. Gender equity, we spoke about that, which means more girls in schools, narrowing the gender gap. Well, there also, you see it from the red line, what we see in reality is below of what we would need. Infant and child mortality, this is of course the closest to us as obstetricians. And if we look at the under 5 mortality rate, you see that this is also way below what we would like to see till 2015. So if we look at the world's annual births, you see the majority is in Asia, and ask what do most children die of, they're often dying of very simple things, lack of oxygen, and you see here that the likelihood of reducing childhood mortality is really there if simple measures would be taken. And this is what the Millennium Goals have in mind. The Millennium Goal 5 is addressing the maternal mortality issue. This is 5A. And we already mentioned that this has to do with the centralization and with the skilled birth attendants. The situation is getting better. We shouldn't, just say that everything is negative. It is getting better, but 45% of the deliveries are still not attended. Millennium Goal 5B is to achieve universal access to reproductive health until 2015. Indicators have been defined. There should be access to contraception, family planning, We have spoken about the teenage pregnancies. We have spoken about the issue of the spacing of the deliveries. And antenatal care means that at least one visit by a skilled attendant should take place. We have all the guidelines, but WHO put out these guidelines, what should be done in pregnancy care, the measurement of the blood pressure, the urine test for bacteriuria, to look for syphilis, for severe anemia, to check the weight. But as you see, this is not given in major parts of the world. So, when in 1990, less than 55% of women had at least one antenatal visit, this number has gone up to 75%, but 75% is certainly not satisfying at all. And WHO, as you know, is recommending 4 antenatal visits. And here, with the 75%, we are speaking about 1 visit. So what we need is much better recording of pregnancies. I'm not advocating to increase bureaucracy. We have enough of that, certainly in our countries. But we have to tackle the really critical things. 35% of maternal deaths could be avoided through better access to family planning. And there's no doubt about that. Even if you are against contraception, these facts cannot be ignored. Reducing child mortality by adequate nutrition would be most effective, and what we have mentioned about the general aspects of gender inequality. You see here that fertility is going down in every continent. You see in your continent is also a quite significant decline. But if you ask what percentage of women still have 3 or 5 children, it's 25%, but 23% have 5 to 8, and this can be a problem in certain regions of the world. So, contraceptive prevalence rate is increasing, but still, there is a significant percentage of the world population that don't have access yet to contraceptive usage. This decreased the percentage, but it's still almost half. So what we need is further research. We have to develop better methods of contraceptions, longer-lasting ones, easy to apply. And there is an unmet need. So, for example, the numbers that WHO reports from 2005, I think this may have changed, but they in 2005 were saying that 27% of the poorest women had no access to family planning, and this is of course a major problem in Africa. Bill Gates Foundation is helping a lot. FIGO has a program with Bill Gates, a 10 million program with 10 different countries. And I think he has realized, he was first only interested in vaccination, now he has realized that maternal child health is important. And he says that if you improve health in a society, population growth goes down automatically. And I think this has been seen in many parts of the world. If you look at the numbers, for example, for Malaysia, you see a very, very clear correlation between the increase in wealth and the decrease in the population. So if we summarize these Millennium Goals and what has been achieved so far, you see that in some we are doing okay, access, safe water and so on. In some others we are doing very badly, and especially those who concern us, maternal and child health, we could do much better. So what are the recommendations that we can give? Well, I've mentioned a few. Contraception is one of them. We have to really build those centers that are then accepted by the population. And I think we cannot avoid to address the issue of the unsafe abortions. The estimate is that currently per year there are about 68,000 maternal deaths due to these complications. And there is a distribution, of course, in the world. So if we want, in summary, to reduce maternal mortality, we can learn from those countries who have achieved it. They have used skilled birth attendants, they have an easier access to emergency obstetric care, the transportation issue they have tackled, and they also have reduced unwanted, unattended pregnancies and access to contraception. And I want to finish by mentioning positive examples. I think we should not just get depressive and say nothing can be done. I think there are fantastic examples of improvement in the world, and let's quickly look at some of them. For example, if we look at Thailand, you see, starting in the 70s, fantastic decline. Egypt had a decline. These are just examples where I have some personal experience with, and the same was even seen in Europe, that within the same time period there was still some improvement in these figures, down to the low levels that I have mentioned, and also the perinatal death rate went down quite significantly, to the very low levels now, which are very difficult to improve. But let's look at some examples in detail. Portugal in Europe. 1989, they looked at their figures. They were not satisfied. And then they started a national program defining the levels of perinatal care, defining the units, level 1 to 3. They started a much improved system of neonatal transport, and they did special teaching courses for pediatricians, neonatologists. They closed small units. 150 public maternity units were closed. So the number of delivery units decreased dramatically in the country, and all of this led to an amazing improvement. The maternal death rate decreased from 9.2 to 5.3 in 2003. Perinatal mortality from 16.4 to 6.6 per thousand. This is what you see in most European countries now, but most dramatically the neonatal mortality from 8.1 to 2.7. So I think we can really congratulate them, because this results in a decrease of infant mortality from 12.2 to 4 to 3.8 in 2004. So we can make progress, and the neonatologists have told us, learning from these examples, that we have to define these levels of care. We have to get the mothers educated. They have to have an easy access, of course. Breastfeeding has to be promoted. Then there has to be some investment in these most important machines that we need. Guidelines have to be adapted for the individual countries. This is capacity building. And then the essential drugs that have to be used in this phase of life should be freely available. But I have mentioned only this one example from Europe. Here you see other countries that have done especially well, and WHO also lists Colombia as one of the very positive examples with very remarkable progress. So you find positive examples in all continents, and I think probably this hasn't been evaluated systematically enough. Turkey is a fantastic example. 1974, maternal mortality rate 208 per 100,000, now below 25. So this is fantastic. And what did they do? Well, they provided vitamins, better nutrition to women. They started better prenatal care, monitoring for sexually transmitted diseases. They also trained more birth attendants, but they also defined their perinatal centers. They had public campaigns reaching women, especially underprivileged women, and it worked. Bangladesh is a good example. They produced protocols. They just didn't take them from other regions. They applied them to their country and then used the mass media to distribute it. Bangladesh introduced programs for safe abortion. It was a big issue before, but they did that. And they also the other social things like microcredits, of course, helped, and education in general. Honduras is often quoted together with Sri Lanka for what they achieved. I think they cut their military budget in favor of these healthcare expenditures. And I think one of the prime examples in the world that we all can learn from is Sri Lanka, because they really were able to define the hospitals so that now there is a whole national network with these different levels, starting from the district hospitals to the teaching hospitals. And this is the reason that they did so well with improving their figures. So, in summary, we can say, yes, the situation is not satisfying at all, but we have mentioned a few positive examples that we can learn from. And you might be quite amazed to see that if we look at a high-income country like USA, the figures haven't improved much lately. The most recent report doesn't show any further improvement in the USA. Actually, the Lancet report showed that it was getting a little bit worse. So no country is really safe, and we always have to watch what is happening. Let me conclude. I started by mentioning that every minute a woman dies. Every minute 380 women in this world become pregnant. 190 women every minute face an unplanned or an unwanted pregnancy. 110 women every minute experience pregnancy-related complications. 40 every minute have an unsafe abortion, and 1 dies while giving birth. So this is something we should never accept, because it creates these orphans, it disrupts families, it has all these follow-up problems. Coming back to these 2 examples that I've taken from the same week, 2 deliveries, I want to conclude by quoting WHO, because WHO has written in its constitution, the enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being, without distinction of race, religion, political belief, economic or social condition. This is what WHO, FIGO, and all of us have to work for. Thank you very much.